That's fine. Hold on. Yes. Yes. So me and Chanel, it's my lovely wife, Chanel. I'm gonna let her do the majority of the talking, but I'm gonna introduce who we are. So I'm Josh, this is Chanel. We have a wonderful company called New Life Private Care, where we're helping families all over Georgia. And we specialize in kids under 21 years old that are medically fragile children. And that can be from anything from cerebral palsy, obviously Down syndrome. We've been helping a lot now, which is so amazing. And we'll get into that and why that's amazing to us right now. Spina bifida and so many different ranges that we've been finding and seeing different families and being able to help them. So how it works is we've partnered with Medicaid. Medicaid has a program called the GAP program, Georgia Pediatric Program, which literally I don't think much parents know about it. And if they do, they don't understand how it works. Hence why I've been hearing that a lot of families have gone in to try and get the program and they've had a denial letter. And that's because they don't have the right guidance. And that's what we're here for. We are direct partners with Medicaid GAP. And what we do is we offer this GAP program to help our families get in free in-home services, where we send out our CNAs or nurses, depending on the nature of our family. And we send our nurses or LPNs or CNAs and making sure that we give free in-home services, which is required for them by the state. And it could be ranged from anywhere between 16 to 25 to 30 to 40 hours. It all depends on the case. And we're doing such a great job. We have over 30 plus families in the first year of opening. We grew very quickly, and we've had 100% rate so far. And that's because we're very diligent with how we work with Medicaid and GAP, and we're very on top of things with our families, making sure we do all the paperwork and processing, and making sure that it gets to the board of doctors that we work with over in GAP, making sure that they, we put our families through. And if we're not going to be put through, we need to know why, and we need to go through down that staircase of reasoning. So that's kind of what we do. Chanel, you want to add on to that as well? Or?
Yeah. So we're able to, the GAP program is not a waiver program. It's a Medicaid program that, as Josh said, a lot of families don't know about. And so this is for any child under 21 with any medical necessity. So it can range from unskilled needs. So we provide either personal care assistants, CNAs, or we also have the option to pay the parents for providing these needs. So the bathing, dressing, feeding, incontinent care, anything that a child is not able to perform for themselves due to their functional limitations. So really the only criteria Medicaid has is just any child that cannot perform physically the same as their peers. So that will get us through for providing unskilled hours. And then we also provide the most complex medical care for children with skilled needs. So these are children with G-tube feedings, ventilators, oxygen, seizures, just a range of any kind of skilled need that they need at the home, so that they can have a skilled nurse come to the home and perform these duties for them. And so what we do is once we meet with the family, we just get a little information and get some forms that Medicaid requires filled out. And what we do is communicate with the doctor. So we speak with the doctor and get some medical history and documentation, as well as a referral from the doctor. That's usually about the longest part of the process because it's making sure that the doctor is providing all the information that we need. And we don't submit an application until we know that we have checked every box and we have painted the best picture for Medicaid so that they know exactly what this child needs and that there's a need for it, that there's a need for care. Then we submit everything over to Medicaid, and Medicaid gives us an approval typically within 30 to 40 days. Right now they're running a little behind, but once we get that approval from them, they let us know how many hours per week the child is approved for. So it, as Josh said, it ranges. It could be anywhere from 16 hours to 40 hours for unskilled care. And for skilled care, there's no cap. So skilled care can start at just a few hours a week, all the way up to 100+ hours per week, depending on the child's need. And then we once we have this child with us, they're with us until they're 21, and we continue to recertify every few months up to a year, depends on Medicaid. You know, every case is different. And we provide medical documentation, and we continue to update the doctor with our records so that we have a good partnership and a relationship. If the child is hospitalized or if there's any change, we share that information back and forth so that our medical team can be most up to date with the child's needs. And yeah, we can always let Medicaid know as well if there's an additional need for more hours or a change in the patient's condition.
Okay, perfect. So I have a question or two. For those of you guys that have just joined us, this again is Josh Newell and Chanel Newell from New Life Private Care. They are providing us information about their agency that helps with gap waiver. If you have any questions, please put them directly in the chat. I will read those off to Josh and Chanel, and they will answer them for you. So I do have a question. It's from Raven. And she said, is there a fee for you guys' service?
No.
Nope.
Completely free for the parent.
Yeah.
We bill Medicaid for the services.
Right.
Perfect.
Medicaid has
Okay.
to take care of that. Nothing to do with the parent.
Okay, perfect. As far as after 21, do you guys help with any transitioning? Like, what do you do? Do you provide any assistance?
Well, we're actually working on our license for over 21 right now. So we're going through the paperwork now. Hopefully by between March to May of next year, we should have our license for the over 21, where we'll be able to continue servicing anybody probably 21 and above. So that would be excellent news. We're very hopeful, and I think we're definitely going to get that done. So yeah, we'll definitely have that option of continuing if you want to continue on past 21.
Yeah, because we definitely want to utilize your services, especially within our group, so that from birth to all the way to the end. So yeah,
Yes.
it's good to know that you guys are working on that. I have another question, and that question was, what's your motivation for starting this? What was your motivation for getting this started?
There's a couple of motivations. My motivation is, well, my mom, I'm originally from London, England. I don't know if you can tell, but my mom's been my mom's been in the medical field for over 30 years. She was a traveling nurse. So from the young age, I would say of 14, she made me work with her, and she was focused on the senior staff, group. And I don't know, she instilled this passion in me, man, of understanding, just humans in general, of understanding that not everybody is the same, and, different paths in lives. And so I've always had a passion for people. And then it's weird. We were staying in, we live in Georgia, as you know, but we were staying in Florida, where my wife is from, for the last, I would say 8 years now, 9 years. And then in 2019, I was unwell that year. I was hit with a migraine sort of condition called hemiplegic migraine, and what it done is it kind of shut down, I guess, half of my body, I don't know if it was stress or anything. I don't know what it was. Till now they don't even know what happened, but it happened for a reason, because once that happened to me, it kind of just made me, I don't know, I just saw life different. And I just said, you know what I want to do? I want to just help people. When I get better, I just want to help people now. I feel like I've had a great life. I've traveled, I was an ex-professional soccer player, or what we call football in England, for many years. I've traveled the world, and I've had a great life, and it's time for me to give back and help. So I was very passionate recovering from that. I was very passionate. I wanted a new change of scenery. So I feel like God brought me to Georgia, me and my wife. And when we settled up, I met one of my best friend now. He's a mentor. He's been doing it for 10 years. And he took me out with him, and he was like, look, these are the things that I do. I've been helping these children for so many years, and you and your wife would be excellent. And at first I was like, wow, I could do that. And he said, yeah. And he trained us, and he kept us, he kept his arms around us to make sure we understood what we were doing. And yeah, we ever since then, we've just been on the ground running, just trying to scream out the top of the mountain of, as much families, like, let me help you, let me help you, let us help you, let's help you. Like, this is really here. And like Cheryl said, when I met Cheryl, it was exciting, because one thing with me, I like to compete. So I know the resistance was there in the beginning, which it should be, because she explained there's been a lot of cases where people have been let down from maybe other agencies or Medicaid themselves. So when she told me, and I said, all right, look, give me a family. I'm going to make sure I put this family through. We're going to make sure it works, because we have a system. Me and Chanel. Chanel is the genius behind everything, and I don't know how she does it, but she's on those phones with those doctors, and me as well, but mainly her, and they just seem to like us and want to help us. They see what we're in it for, and they want to help us. There's a lot of providers out there that are just doing it, and they're not understanding the importance of it. They're not understanding and listening to what the parents want. And that's something with us. Like, yeah, even April can tell. I tell April all the time, if she needs me or she needs, she call me anytime. Doesn't matter. I promised her, and along with the other three that they gave us, and I promised Cheryl that would get them through, and we did. And we've had 100% record so far with you guys so far, and I'm hoping to definitely help much more families. The only thing I always tell Cheryl is listen, if we know we can't help them or not us, or we know that Medicaid won't put this particular family through, we will tell you from the intake, tell you from that meeting, this is what's going on. We got to do this, unless your doctor, because at the end of the day, it's all they're not going to pass anything unless they read, the PPOT, what the doctor has written down, and that's what comes to it. So we can't, we don't give miracles out. We don't give it, but we can tell you from the get-go, this is going to get through. Let's go with it, and let us give you the help you need or the finances that you need. Or if it's not going to help, if it's not going to work, we'll also tell you on day one. We don't want to string anyone along and say, okay, yeah, we'll try, and then do it. No, there's a lot of agencies doing that. I'm getting to find out, and it's very wrong, because what happens is you're wasting out the next 30 to 40 days knowing that person's not going to get out, and you're wasting their time, and we're not into that. As Cheryl will tell you, we just tell you this is what we can do, let us do it. And so far it's been excellent. So again, we thank you guys for at least listening to us, and we're excited to just help you guys as well as much as possible.
Yes, thank you so much for sharing that with us. That's an amazing story. We really are glad that you have a passion for what you're doing, because we feel like sometimes that's lacking when people are seeking services or help from, agencies. So we really appreciate you guys, having that passion. We have another question from Jamila. She's asking, what is considered unskilled care?
Okay, unskilled care is a child that does not have a skilled need. So that would be like something that requires a nurse, but they could use help with their activities of daily living. So they're not able to bathe themselves, to feed themselves. Typically, they may be wheelchair bound. A child who also is incontinent. Those are the things that would qualify for unskilled care. And so that's what a home health aide would assist with, or the parent would also be paid for those hours.
Okay, perfect.
Okay.
Another question from Dr. Talboy. She asked, if Medicaid rejects the application, is there still no fee from you guys?
No fee.
No.
No fee ever. And if
Okay,
they
no.
do reject, which we haven't had that case before, but if they were, there's always an appeal process that we can assist you with as well. We have had some people, some parents that have appealed to ask for more hours, and that has worked. So
Right.
we help guide you through the appeal process as well.
Okay, perfect. Does anybody else have any questions?
I don't have a question, but I just wanted to say, since I am a paid parent, Chanel and Josh has definitely made the process easier. They keep you up to date the entire time, answering all questions that you do have. In the process, as far as clocking in and clocking out, is fairly easy. It's definitely worth it if you are able to apply and get your application received.
Thank you. Thank you.
Thank you. Thank you, April. Honey, if you got a stamp from April Forte, listen.
Thank you, April.
And we're a family. We're a family with all of our patients and parents and staff. We like to keep it tight, and we're always in communication, calling, texting. So yeah, we definitely keep it tight.
Okay. One more question here, and we'll make that the last question. It's from Yvonne. She asked, what are the qualifications?
So
Cool.
Medicaid's guideline, they don't put like a definitive criteria to it. They just require any child who cannot function as their peers. So a 7-year-old should be able to bathe themselves, dress themselves, feed themselves. So any child who cannot function as their peers would qualify. And of course, any skilled care would qualify. Now, I do want to make note that currently Medicaid GAP does not see autism as a qualification. That's kind of been a battle, and we've been trying to advocate for parents with children with autism. And they are working on, they say they're working on it, and the program should be coming soon, 2023. But as of now, the primary diagnosis as autism does not qualify. If there's a primary diagnosis of something else and then autism is secondary, then we can definitely work with that. But autism on its own does not.
All right, perfect. Thank you.
Sure, thank you.
Mhm.
All right. Well, thank you guys so much for, again, coming on, providing us this amazing information. If people would like to actually take part or receive your services, how best can how can they get in touch with you? Should they go to your website? Because we will post that on our page. Is that the best way, or what's the best way to contact you guys?
Sure, they can give us a call. That's always the best way. I answer my phone anytime. They give us a call. They can go to the website and email, send us a request for information or a message. And also, if any of you all are working with the family and you want to reach out and give us a call or a text and just let us know, we'll be happy to reach out to the family as well. Yeah.
Okay. You guys mind throwing that phone number in the chat for us?
Sure.
And we'll get it posted as well. But yeah, just for the folks that are here, they can go ahead and have it right now.
Nice. And we'll do our email as well, just in case the email.
All right. So thank you guys so much for coming on tonight. So now we'll move on to Dr. Amy Talboy. Hey, Dr. Talboy.
Everybody, thank you so much for having me on here. I'm so excited to
Are
see you
welcome.
guys.
We're excited. We're excited that you're here. Do you know people were going crazy when I posted you to Facebook? They were like, "That's my girl. I love her." Everybody
I
was
love
just
all of you.
everybody was so
Group hug.
Yeah.
Yeah, no, I absolutely love my DS patients and their families. You guys are just the bomb. In case for those of you who don't know me, my name is Amy Talboy, and I am the medical director of the Down Syndrome Clinic at Emory. We have, I see quite a number of patients actually. Most of my week, every single day of the week except for Fridays, is largely spent seeing people and talking to families about Down syndrome. So I'm really happy to be here and ready to answer any of your questions or issues that you might have. I just want to, you didn't tell me to prepare anything, so I didn't. So you guys just kind of lead the way, and we'll talk about whatever you'd like to talk about.
Yes, so it was just a Q&A. I did a real big bio on Facebook, so if anybody got on here, they more than likely read the bio, but you can feel free to, explain like what you normally do like in a session.
Yeah, so I am a pediatrician, and I'm boarded in two specialties. One is pediatrics and one is neurodevelopmental disabilities. So in this clinic, we start right at birth or as soon after as possible. I've been to a number of NICUs in the state of Georgia and given them information. So we do get a lot of referrals right straight out of the NIC, right straight out of the nursery, and from pediatricians and such. We try to, for new babies, people are always asking me about clinic and referrals and how to get in and things like that. So for new babies, I save appointment slots. For Thursday is new baby day, and we have genetic counseling associated with that appointment. When they come in, we have the genetic counselor. I think everybody who has a new child with Down syndrome should have the benefit of seeing a genetic counselor and getting everything, all their questions answered from that perspective. Also, I like my patients to, have somebody to talk to besides me, because sometimes when you're brand new, it can be intimidating just to come in and talk to the doctor. So it really is helpful, I think, to have the genetic counselors go in, talk to people, answer their questions, tell them about me and what our clinic is about, so that when they come in to see me, they're not anxious anymore, I hope, and things, I can kind of take it from there. And actually, sometimes we do get really complicated genetic diagnoses that really do require pretty complex genetic counseling. So that's what happens. Then I see the babies and examine them, and we kind of introduce what to expect from our clinic, which I'll tell you in a minute. Tell them what they need to know about medical standards of care for newborns, and not go into such great detail about later in life, because we're not worried about that yet, right? So those are the babies, and once I see a baby, I will see them back probably, and depending upon what's going on with them, but we get them connected to resources in the community, medical resources that they need. I have a whole variety of specialists and subspecialists within the pediatric world who have particular expertise in their own area related to Down syndrome. So there are a variety of ENT doctors and ophthalmologists and other people, GI doctors and all that sort of thing, who have more knowledge than others about the specific issues of Down syndrome. So it's more like a multidisciplinary model. Nobody at Emory is in the same place. It is impossible almost to have a clinic with everybody together unless you have some specific medical problem and you are at Children's. But at any rate, we're connected with a number of people in the community who, and at Children's, at Emory, and privately, who do a lot of work with Down syndrome. And so we get people connected there. I monitor development as time goes along. So during the first 3 years, I typically see people every 9 months until about age 3. And then if everything is good, it's once a year. Maybe a little bit more frequently if there are concerns or issues. Older kids, I see more often if they're on medications that I'm prescribing and things like that. So there are certain predictable moments in life when I think that I can be more helpful than others, like transitioning from middle school to high school to babies can't wait to special needs preschool, to kindergarten. There are certain transitions that I try to see people back before. But in general, I think my job in terms of developmental peds is to monitor development and make sure that things are progressing, that the child is progressing in the way we would expect and hope, and that the therapists are doing what the therapists are supposed to do successfully. So I am involved in sort of the whole intervention, overseeing sort of the intervention, the big picture of interventions. I spend a lot of time getting people connected to therapists, or giving directions on how to find therapy, and resources and things like that. Everybody that comes in to see me gets connected with DSAA, if I try to, and other support organizations in the community. And you all should well know that the DS community is as supportive as I have ever seen any community support one another in really in any area, but especially here. So you're really fortunate to have this organization and this group that can connect you to people like the Newells and other organizations to help, and have discussion about it. There are a lot of other conditions that just don't have this. So I'm just really thrilled to kind of be a part of it. And it is really helpful to me as I see patients in my clinic. But I guess that's kind of the overview. So I want to make sure that all the standards of care for medical care for Down syndrome are met, that I monitor for all the for a lot of odd and strange medical conditions that might arise or come up that are more prevalent amongst the DS population, and that your developmental needs your development is progressing appropriately. So that's kind of it. That's my spiel.
Okay.
Question?
Yeah. I'm having a little tick. Am I up?
Yeah, you're breaking up and you're frozen.
Raven.
Yes.
Somebody take over. Okay, somebody take over for me. Let me figure out what's going on.
Yeah, I'd be happy to. So I know I actually asked a question to Maya, but I see that Cheryl asked one too. So if any of you posed a question to Maya directly, I can't read that, but we can get back to it when she's back online. So Cheryl's wondering, Dr. Talboy, about transitioning to adult doctors. Like, at what point should our kids transition?
So, we need to start talking about transitioning early. I think the standard is about age 12. And that may seem really early, but it's not. People just have to start to think about what is coming up in the next 4 or 5 years. And there are certain websites in different places that can kind of help with what you need to think about. But in terms of my clinic, when a patient approaches adulthood, now in all reality, I have people in their 20s, but I am a pediatrician. Taking care of adults is really outside my scope of practice. So what we have done is we have kind of set up this transitioning model for medical care, whereby people who there is a primary care provider, Emory Primary Care in Decatur has internal medicine doctors who are super interested in people with disabilities and other things. And one of the people in their practice is particularly interested in Down syndrome. And I was so thrilled to find this group and to connect with this group. It's a long story about how I found them, but I looked for years for this group. Finally found, I couldn't believe I accidentally found them, but at any rate, for primary care, they can take on primary care kind of as my sort of adult counterpart. So for a couple of years or for a year or so, the people that I refer for adult primary care there, we overlap. So it's not like, okay, I'm done, here's somebody else. We have a transitioning period, and I'm there to support the adult doctors in terms of Down syndrome issues. They are learning about the patient in terms of their medical issues. And when they start seeing this group of adult providers, what I like about being in the, I mean, you don't have to go to an Emory doctor, but what I like about this model is that if you have a lot of medical problems, there are all kinds of medical problems that arise in adults that you aren't even there in children. If you have a problem and you need specialists, or you're coming into this transitioning where all of a sudden you're over 18 and you can't go to children's anymore, then Emory has excellent specialists, right? So we're a big university with all this academic medicine, and there are lots of people in all kinds of specialties, all sharing the same medical record, all taking internal referrals, so that that primary care provider can refer their patients to whomever they need to see, including behavioral health, including psychiatry, including a number of specialties that, cardiovascular care, neurology. There are a lot of different options. So and then adults may or may not have a parent to give their history, right? As we age. And I think having a medical record that documents everything is critical when you are aging with Down syndrome, and you as the individual can't necessarily give a good history on yourself. And so that's my model. We transitioned to primary care, and we are still within the university system with all the information there. And if we need some help with things that are more like advocacy or other supports that are kind of outside of the medical field, we have the whole group here. We have the DSAA that we can, involve. So the adult clinic, the adult doctors often call me to talk about things that they don't quite know much about related to their patients with Down syndrome. So that's the adult, that's how we're handling adults right now. Now, does that work for everyone? No. There are some people who don't live close enough to here to be able to do that. And that we just do the best we can and try to get them hooked up with the people that they need. But I kind of like the model. So far, I really am liking the model that we have with the primary care folks within the Emory system. So that's what I've been doing.
Yeah.
It's pretty new.
And that's actually a question. One of the next questions, Dr. Talboy, is do you refer to other counties? It's
So,
tough sometimes, if you live South Georgia, 4 hours away to get.
Yeah, so I don't know who to refer to in every corner of the state, honestly. If somebody needs to see a specialist, then yes, we do here. I know who to send here. I have been challenged even in pediatrics in finding people that I feel good about in some areas. So, we're really talking about, sometimes we're talking about really specialized services. And sometimes they just have to come to Atlanta for certain types of doctors. But I do try to refer to other counties. I look for, certainly with regard to therapy and things that can be done locally. It just depends on the problem. And there are a few areas that the entire state is lacking, like psychiatry.
Mhm.
So psychiatric care, not just for peds, but for anybody, is just, there aren't very many. It's really hard.
Yeah.
But luckily for those that I think really, really need it, I've been able to get them into to psychiatry, but I really try to reserve that for cases that I don't just refer, some kind of mild condition if I can help it. So,
Yeah, thank you. There's another question from Deidre. Deidre, you might have to explain this one. I think you probably asked this when Dr. Talboy was speaking about something specifically, but the question is which clinic or doctor? So do you want to?
No, I think I didn't hear. I think I heard her say that they work with a doctor, or I wasn't sure if there was a doctor in particular or a location in particular for.
Yeah. So the answer is sort of yes and sort of no. So I don't just refer within Emory. So let's just give an example. So everybody should really have an ear, nose, and throat doctor, right? As a child, most everybody. And there are doctors within Emory who are absolutely superb that I refer to all the time, but there's also a private group that does a lot of work with Down syndrome. And there are also some other individual people who do a lot of work with Down syndrome. So when I see a patient, I try to talk to them and think about where they're located, what their insurance is, where, what would be the best option for them. And I share all that information and together we decide.
And how does that happen? Or how can we, for those of us who won't have kids that will come to the clinic, my son just turned 22. So we're transitioning to adult. He's been with Kaiser, but for me, he needs an ENT because he has hearing loss. So that's a specialty that we need. So I'm just trying to figure out if I chose not to go to Kaiser and I wanted to go outside, how do I find those specialists that you were talking about that work, that are particularly interested in people with Down syndrome?
Right. So there are people with,
and just so you know, I live close to the Emory camp, so I'm in the vicinity of the Emory campus.
I think
Eggleston. So I'm in this area.
Yeah. So you're in a perfect area. So I'd probably recommend that you look at Emory ENT. There are, so the adult world is just sort of taking on these people with differences. And I think that the Department of, so your primary care provider, I'd have them refer you. I'd ask your current ENT who they recommend at Emory as a next step. That would be what I would do.
That's a good idea.
Yeah. And they can refer directly to their adult colleagues in ENT.
Yeah, the challenge is,
if for some reason you have a negative experience, that information needs to spread, because I know that there may be certain doctors within, there are a lot of ENTs at Emory. There may be certain doctors who are more interested in the Down syndrome standards of care than others. And that's true anywhere. But that's what I would do. I would ask for, usually the pediatric ENT will kind of know who to refer to in the adult world.
And the challenge is our ENT sees peds and adults, and we like him. We're
Then you can stay
transitioning.
with him, right?
Well, he's in Kaiser, and Kaiser's
Oh.
an HMO. So we've lost our pediatrician who retired but was excellent with him. But I haven't found within the Kaiser HMO the same experience just yet. So it's really just looking at what the options are for him.
Yeah, that's kind of hard. So I think that, or does he have the need for a bunch of other specialists besides ENT?
Just ophthalmology, just ENT and ophthalmology.
Okay. And his primary care provider is in what system?
I'm sorry, say it again.
Is his primary care provider, whether it be a pediatrician or family practice or some adult provider, are they with Kaiser? Or are they with someone else?
We're all in the Kaiser system. We lost a little bit of continuity of care when the person who'd seen him from 1 to 19 retired. And so there's been a hodgepodge of folks in the last 2 years, especially given COVID. So we lost that consistency with folks who knew him very well and knew our next steps, because
So
a lot of it is COVID. We can blame it on COVID, right?
yeah, you know what? I think in your situation, I'd consider trying to stay at Kaiser because they've got all his records and they have all this different specialists. If you could just find the right person within that system, it would be
I'm not too happy yet about that. I haven't made the move, but it's just me looking at my options because I'm not happy with what I've seen in his primary care situation.
I think you have options at Emory, and I think you maybe have options with Wellstar.
Right. So if I went outside of Kaiser, that means changing insurance, which is where I'm at now. Because just asking, just trying to look at what my options are.
I gotcha. I don't have a really great answer for you there, but there are a few options.
Appreciate it. Thank you.
Okay, here's a question. As far as research, are you or Emory doing any research when it comes to outcomes for African Americans with Down syndrome, like life expectancy, medical issues that can be specific to African Americans? Well, the answer is, well, I can tell you what we're doing and how they're looking at those specific questions. So one of the projects we're involved with is looking at child development in outcomes in children who have had heart surgery and those who do not have heart defects, to see if there is any difference in developmental outcome. So Emory has the Sibley Heart Center does more open heart surgeries than any place in the country for children. They have a huge number of patients that they have seen. Just to give you a feeling, the study that we're involved in is a multi-site study where there are locations all over the country of places where it's the Pediatric Heart Network, where they did a study at looking at all these heart surgeries in babies with Down syndrome. So they're bringing back those babies now that they're 3, 4, 5, 6 years old and looking at development. And we're going to be comparing them to children who have not had heart surgery. So we have the cohort here who had heart surgery. I'm going to try and recruit people who have not had heart surgery, and they get developmental assessments free. I mean, it's a pretty good deal. It's not invasive or anything like that, that you just get thoroughly evaluated and with some feedback. And the study itself will, it will look at all these people. Other places in the country, they may have like nine subjects, 10 subjects, 11 subjects, 12 subjects here and there. There are about 11 or 12 sites across the country. Emory has 40. That's how big the project is here. So I'm going to have to find all of these people who have kids within the right age range who do not have heart surgery. That's my job, and it's a big job. But that they will analyze the data and sort through and analyze it in terms of African American subgroups and other things. So the way studies are going now, it's not that they just only look at African Americans, but they do look at them statistically compared to other people. So they will, I'm sure that all the data gets analyzed that way now. So the answer is not separate studies, but yes, lots of studies are having cohorts that have where they analyze it that way. I also am working pretty closely and have been for a few years with the chair of the Department of Psychology at University of South Carolina, Jane Roberts, and she has a big NIH grant to look at child development. And she has been looking at autism and Fragile X and other kind of conditions and the emergence of autism and development in those groups. And the NIH, because of advocacy efforts, put out additional funding to include African-American subgroups or cohorts to ongoing studies. So she got one of those grants from the NIH to add on to her studies. And she now has a cohort for Down syndrome in her studies. And that project is fantastic. I mean, she comes here to Atlanta, her team comes, they come in, they do a fantastic developmental assessment, and you don't even have to leave your house. They just come right to you. That's another study we're involved in. And then let's say a third one, here's another example. This is an awesome study. A professor at Georgia Tech is looking, and has been for a long time, but is looking at motor development in young children with Down syndrome. So this is Georgia Tech, right? So he has developed a treadmill for babies. Literally, you don't even have to be able to walk to be on this treadmill. You should see it. It is the most awesome thing ever. It's only about like this big. So you put your baby on this little treadmill and you see the baby like going like this. So the baby is developing these motor patterns from like being held on this treadmill. It's so cute, but it's a really legitimate, serious study, and it really is interesting. And they come to people too, and they come right into your house and bring you a little baby treadmill. And it's an interesting study, and they're great to work with too. So we have some things going on, and it's not just for African Americans, but there are concerted efforts to make sure that all groups are covered and looked at together and separately.
So I just want to add something. So we are actually, and I've actually spoken to Amy about this, because I get information about studies every week, and kind of weeding through what studies we should participate in and what you should give your time to and all that sort of stuff. So there's a group called LuMind that does a lot. I mean, it's mostly research. They're actually going to be speaking, we're hoping in January or February. We're going to get them on a Zoom call for DSAA to talk about how you figure out what studies work best for you and your family and the information that you want. I will tell you that NIH will also be coming on as well, because they have all sorts of studies. And there's a woman here in Atlanta that focuses on specifically the Black community and the Hispanic community. And she is dying to get a hold of this group, because it's really hard to find participants for a lot of this research that's being done. So just to give you an idea of what's happening in the future is kind of one, NIH is a great, group to work with. And then, but LuMind is going to help us kind of figure out, help y'all figure out what research should be out there and what y'all need to know. But I can tell you that having BFC has made DSAA very popular for agencies wanting studies and research to be done to make sure that they are doing specific But again, understanding also that we need to work within the overall bigger picture as well for DS. So I just wanted to give y'all that information.
My clinic in Emory, we're one of the sites for the Lumine Clinical Research Trials Network. And so we right now are involved with multi-site studies looking at natural history of adults with Down syndrome, getting in preparation for future clinical trials of drugs to treat Alzheimer's. So we have a number of subjects going right now for several years looking at their progress over time and gathering data. And whenever the first clinical trial comes down the way, those people will be in line to be potential subjects for those trials. So we're very much a part of that. I've actually, this is for me as a pediatrician, I have actually loved seeing, talking to, meeting, being a part of a project that involves adults. And it's just been really interesting. I've learned a lot from that Lumine sponsored project. So it's really, yeah, so things are happening.
Definitely. Thank you.
Well, we're excited. And this was, I think, a great start. We're at time, which that hour just flew by. So Dr. Talboy, we'll have to have you back another time for sure.
Anytime, just ask me. I'd love to come back.
Well, good. We're going to have you back. We're going to put you on the calendar for next year. We're going to meet soon to put some events together. So we'll be reaching back out. So thank you so much for your time. And anyone else who has, any other questions, where to find Dr. Talboy. I want to say that the bio that Maya posted on the Facebook group had Dr. Talboy's information. And certainly if you haven't visited Dr. Talboy yet with your child, we would suggest that you do that. Go into her clinic, go talk to her, go see her, and use her for all her information and the value that she brings. We want to encourage everyone to do that. So any last thoughts from Maya? I see her finger moving around. I don't know what's happening. Technical issues. But thank you everyone for joining tonight. I hope you got some good information, and thank you, Chanel and Josh, of course. Learning about what New Life does certainly educated me tonight. So I'm happy to pass that information on to anyone that I can think of. So they share their information in the chat. So make sure you capture that if you don't already have it. And don't forget, one last plug, Cheryl, November 16th, we're at the Capitol, right? Okay, advocating. So if anyone is interested, feel free to reach out to us and we can share more information about that. We want to see more of us represented on an advocacy standpoint. So I think you said Yvonne had some information, so we'll share more of that on the Facebook group as well. So Cheryl, any last thoughts?
I just want to thank, Josh and Chanel and Dr. Talboy for coming. I think these nights are so important and they're relatively easy. We can do it in the comfort of our own home. And thank you for the leaders of BFC, Maya and Raven and Yvonne and April. Y'all help make a big difference. And I couldn't be more proud of what BFC is doing. So thank you.
Same here.
Thank you guys so much.
Where we're going. Yeah, thank you. Thanks everyone. Have a great evening.
Good night, y'all. Thank you again.
Bye.
Bye.
Have a great night.
Bye.